Thank you for joining me in this presentation, and we'll be looking at clinical Pilates and just where exactly clinical Pilates will be fitting into the physiotherapy treatment scene over the next decade. Over the last 30 years, clinical Pilates has evolved within the physio profession. DMA started teaching back in the late 80s and it's continued to this day, starting initially with emerging stability research, but since then we've only worked with physiotherapists and evolved it in the physiotherapy practice situation. We've continued to move with the times, and the current thing being the movement-based classification and treatment tool, which we'll be talking about today. We've heard this, exercise is medicine, and Pilates and physiotherapy have become inextricably linked in this exercise is medicine paradigm. And the component also that we're looking at mainly is translating research and evidence into practice. Evidence-based medicine exists, however, there's a lot more work to do. Things have changed. Maybe some of you don't remember these days of mobile phones. Originally they were big things, then they got a bit ugly things. But in physio, we used to have things called Biodex, Cybex, Medex, KingCom, all sorts of measurement tools, and these are no longer used very much because they're looking purely at strength, peak torque and isokinetic output. Things have moved now into much more of an efficiency model than pure strength. Medicine hasn't changed much. Advertising certainly has changed over the last 20, 30, 50 years, but medicine is still doing things that the evidence has proved 10, 20, 30 years ago are no longer effective. So we've got to catch up with the advertising game. If you look at it, is evidence being evolved into practice? Certainly knee and hip arthroscopies have started to come down, subacromial decompressions, but they're still being done despite the overwhelming evidence that knee, hip arthroscopies and subacromial decompressions are of no value. The structure is changing. There's a demand for better value healthcare, and COVID has certainly highlighted that at the moment. There's no more money. Costs are getting greater and greater, and of course we're now under financial pressure to make our system more efficient. We are though seeing more intervention. We're seeing more harm from surgery and intervention, and also we now need to look at accountability. What are we measuring? Are we getting good outcomes? If we look at premature causes of death and disability in Australia, over a 20-year period, low back pain, falls, neck, Alzheimer's, diabetes, chronic kidney, prostate, osteoarthritis, premature death over a 20-year period, half of those fall into the physiotherapy remit. Unfortunately, we're not getting half the money. So that's our job, keep people out of hospital. We only want hospitals there for people that need to be there. One of the things that has, as I said before, COVID-19 has highlighted a problem that we have with our system. In May this year, Birmingham University looked at a study where they compared 193 United Nations countries looking at elective surgery rates. Now, during the first lockdown of some 6 to 8 weeks, how many elective surgeries were cancelled worldwide and by country? Australia cancelled over 67,000 elective surgeries per week over the first 6-week period. That's continued with some states only just finishing in November before elective surgeries were starting to be rolled back to 100%. So that's 400,000 added to the list. We've got now well over 1 million people sitting on elective surgery. These are the non-urgent surgeries waiting to go down to hospital. This will take years to clear. By head of population per million, Australia's 2,685, USA 1,073, Germany, UK, Japan. Australia stands out at doing more surgeries electively than anywhere else in the United Nations and the world. We have a problem. If we just look at things like joint replacements, most joint replacements done in our private health insurance industry, but the data coming out from the Australian Orthopaedic Association's National Joint Registry that 32.2% of hips and 42.2% of knee replacements are no better or worse post-surgery. This lines up with a lot of other studies seeing similar. The other problem we have is the next decade, they're looking at a 208% increase in hip replacements and a 276% increase in knee replacements. We don't have the capacity for this, and not all of them, if we're looking there, 30 and 40% actually need these replacements. So what are we going to do? Well, A decade ago, we were given this challenge: reliable brief assessments that are quick and dirty for use in the clinic. Can we actually get better treatments? Well, the evidence has grown over 20, 30 years, but there's no clear evidence that the better treatments have improved. The research grail was matching treatments to physical predictors of patients. Is every patient the same? They're not. We know this. Are they different? Yes, they are. And we now know what the difference is, and we can predict and match patients. We've been studying this with a lot of groups: football clubs, universities, defence forces, hospitals. It goes on and on. And one of the things, of course, is looking at how much is being spent on surgery, and can physiotherapy have a big place in this area. One of the things we have seen even more recently is that a large percentage, a very small percentage of patients are taking up a large percentage of private insurance money. And this is a big one. 3% of Medibank taking up 65% of their claims base, their money. And this is the group we need to look at as physiotherapists. 80% of the people will take up 20% of the money. These are the easy, acute. You get them in, you do a few exercises, off they go. You do a bit of treatment, off they go. They're pretty cheap, and most of them fit into that category. But up the top, we have this harder core, 20% taking up 80% of the money, 5% taking up 50%, or as we saw with Medibank, 3% taking up 65%. So there's a large dollar being spent on a very small group of people. What can we do? So physios are the experts in this area, actually working out how chronic disease works, not over-treating, but looking at exercise-based pathology treatment. This is physio's point of difference. We can actually look at radiology and compare it to the clinical presentation. Is that radiology a false positive, a false negative? Does it match the patient? We must remember too, with Pilates, we are clinicians, we are not Pilates instructors. This is one more treatment tool in our toolbox. So our job is, over the next decade, look at, do we just treat structures? There's a point at which treating a muscle tear, ligament sprain, you reach a finite point. The 6 to 8 to 12 week acute, subacute. Once it gets into chronic, we've got to look at solving the problems, saving costs, not just treating the same thing over and over. We see this with things such as ACLs. ACL reconstructions don't all work. 30, 40, some surgeons are saying 50% of ACLs, just repairing the structure, they will re-rupture. So we have to look at more efficient practitioners with better outcomes as our goal. Translational research. As I said, evidence, and the evidence base needs to be translated. For many years, we've just gone from the observation to the intervention. We've got a weak muscle, let's strengthen it. The idea being what we see needs to be addressed. Transversus was a popular one, wasn't working, let's strengthen transversus. It didn't carry over. And it's a bit like saying, well, I've got a flat tyre, let's pump it up. That's the intervention. But we find it doesn't work, and we keep pumping up the flat tyre, and we haven't actually solved the problem by looking into the translation model to then come up with a better intervention. Find the problem, which in a flat tyre analogy is the nail. Get it out, then you can have a resolution of the problem. So Pilates, where does it fit? Well, over 100 years ago, in the culture physique era, Joseph Pilates started exercising using spring-loaded machines. He wasn't the first, but he was one of many in that era looking at exercise, fitness, and, as we said, the culture physique. It was a bit like Carl Benz had a good idea. However, Carl Benz moved on. Now, I wouldn't mind one of those. Clinical Pilates moved on. We started looking at ultrasound on transversus, pelvic floor. We've even moved on from that with the evidence changing. So it's been a continual and constant change. Yeah, Pilates isn't actually all that safe. You can get problems where patients don't respond the way you'd want them to. And again, what's different about clinical Pilates? Well, one, it's not done in a gym setting. Even the groups and classes situation comes further down the track. This is treatment. And what we were doing is moving on from structure-based treatment and classification. As we said earlier on, the idea of treating pathoanatomy has a finite point. We don't continue to treat a muscle, we shouldn't continue to treat a muscle beyond 6 to 8 to 12 weeks, a muscle tear. We're finding even with things where there is frank damage that they can also be treated better with movement-based classification as opposed to a structure-based classification. What is it? Well, when we start looking at structure-based classifications, we know things like shoulder tests. How many structure-based shoulder tests are valid? Not many, if any. And this is a problem. You know, we can't keep on using structure as our primary driver, using pathoanatomy as our primary driver for management. So this thing of model of direction has been around for a long time. Treatment, exercise in a specific direction still holds good evidence behind it, better than structure-based or muscle-based. Every patient is different, and that difference is their response to directional loading. There's a lot of discussion about loading these days, but the more specific of it is direction of that loading. Not everyone will respond to the same loading in the same direction. Classic example of that is the tendinopathy research. Not every patient responds to eccentric loading in relative extension, which is the standard. So transversus, very popular muscle many years ago. This is back in 2004, 16 years ago they found that it was directional. Donna Urquhart did some studies looking at transversus, finding, well, it doesn't actually do much in neutral, you've got to move it. Put an EMG on chap sitting in a chair, rotation to the ipsilateral side, sorry, the contralateral side, the opposite upper fibres, but middle and lower fibres didn't fire. Going ipsilaterally, the middle and lower fibres on that side fired, but not the upper fibres, the assumption being the opposite fired. It responded to movement. It had this regional recruitment. Now, we all know the work on transversus has actually also been backed up by Gary Allison, people like that, looking, it is directionally specific. It's not a bilateral corset. It's not a stabiliser. It's the only muscle that actually works across gravity directly rotated to rotation. How many sports, how many functions, how many traumas involve rotation? A huge number. It's a direction. The hypothesis, Sue Morris back in 2012, 8 years ago, said no, it doesn't work as a corset, it works contralaterally. It's not symmetrical, it's not independent of perturbation movement, using arm loading on one side, the opposite side fired. So we can't justify training this bilateral pre-activation. In fact, it made people move very strangely. They started bracing, they started walking like thunderbirds, didn't actually know how to move smoothly. 2013 was the end of it. So from 2013, we had to look at this directionally specific patterning. We were already seeing it, but this put the death knell to transversus so we could move on, not just looking at single muscle approaches. So we started researching this, looking through Singapore General Hospital to begin with. Well, does Pilates have any grunt? Now, what we were seeing at that point, systematic reviews, it was better than doing nothing. Excellent, but when compared to other exercises, comparing apples to apples, the numbers there, p-values, should tell the story. The studies weren't that great, careful, and we need some RCTs. So we moved ahead and did the RCT work. The problem being we had to make sure that we were patient-specific, not generic. Also getting away from this generally static muscle-specific activation model. Pathology. Patients come in with pathology, they come in with problems. We needed that included. We looked at subgrouping. Patients are all different. Can we subgroup them rather than treat them the same? And get away from symptomatic management, look at the problem underlying the symptoms. So the first RCT was looking at a chronic low back pain population, and this was comparing apples with apples. Clinical Pilates versus general exercise, and only with chronics. Getting them on the equipment, only delivered by physios, only chronic low back pain. The average was some 14 years, which some were afraid of. We said, may as well do it. We'll soon know if 14 years is too long. And looking at 6 weeks follow-up, 3 to 6 month follow-ups, I should say, after 6 weeks. The general exercise group, Basic explanation, they've given all the same exercises, multiple directions, as we see with many programs, many protocols, everyone's doing the same thing. Twice a week for 6 weeks. The clinical Pilates group was subgrouped on a directional preference. Every patient had this directional preference. Some liked flexion, some liked extension. Many had problems on one side, not so many problems on the other side. We use this simple model as the criteria. Same thing here, flexion, extension, neutral, left or right. Same thing, twice a week for 6 weeks, and they're given a group of exercise on the equipment. So an exercise such as this would be looking at extension biased exercise. So she's maintaining extension through the system. This exercise is looking at extension on one side, so this is a left extension biased exercise. We wouldn't be doing it on both sides. This exercise is a flexion exercise. This exercise is a flexion exercise, and we don't mix up our flexion and our extension and our unilaterality. At the end of that study, both groups improved P001. So this is good. We know that exercise is better than doing nothing. But we also had a very low dropout rate, which was good. A lot of studies, 30% is not uncommon. So 4.6% was good. General exercising group improved by 29, whereas the clinical Pilates group improved by 46. So there's a measurable difference between the groups, which on baseline adjusting still came up with a measurable difference, and very close, 0.07 versus getting to 0.05. And like with any research, there were problems, there was more research to be done. So the good thing is we found that there was a better close with a 14-year average. This can address chronic conditions. More to be done. When we start looking at patients, we see this. Shane Watson, cricketer, shoulder problems, back problems, side problems, groin problems, a hamstring that seems to go every happy birthday, and calf problems. We hear this very commonly with a patient. I'll tell you, all my problems are on one side. This is more commonly than not. We've been through major football teams, major soccer clubs in the UK, Olympic squads. Mr. and Mrs. Smith, this common asymmetry of problems, the predictor, their next problem will be on the same side as every other problem that they've had. How does this help us? Well, quite often we get sort of a bit mixed up looking at detail. Yes, it's an artistic shot, but you got distracted. You didn't see the big picture, you didn't stand back. It's a Sigmund Freud. We look far too much for small detail and don't see the big picture by standing back. Okay, what else is going on with this patient? Is that knee problem the real problem or part of a pattern of problems? So as I said, working with some of the clubs, such as in the UK, looking at how high can they jump. So this is a validated tool, measures flight time in the air, and it's a validated outcome measure. So we've got some group of footballers, elite level soccer players. How high can you jump on the left? How high can you jump on the right? Same thing, going through that team, from the captain down, most of them had all their problems on one side. And in this situation, how high could you jump on the left? Can't jump as well on the right. We then set about doing a matched bias program to one side and one direction. Modified their strength and conditioning, modified their training, so they only did this asymmetrical unidirectional program. Measured them again, you could jump higher, particularly on the problem side. We then had permission to go and do the wrong thing, and the thing was, if you break them, make sure you can fix them. So we did the unmatched bias, did the wrong exercises on purpose, and performance deteriorated, even on the good side, which then going and correctly match biasing improved again. Now this was all happening within subject, within session. So it wasn't happening over a number of weeks or days, this was happening in a matter of minutes. And we've been documenting this as to how long this actually took. So looking at the predictive validity of this process, we did a study through Otago University and looking at time to stabilisation, which included how high do you jump and then also ground reaction force landing on a forced platform. The longer it takes to stabilise, the shorter it takes to stabilise, the better. So this was looking at a quicker perturbation control time being validated. Looking at two groups, looking at time to stabilisation, AP and mediolateral, and the hop, flight, landing situation. Now, we only did 4 exercises this time, not the 8 to 12 in the RCT. How few can we do? MAT exercises, reformer exercises, matching the patient's bias, measure at the first period. They had improved as predicted. Then the same group did the wrong exercise on purpose, and the predictor at remeasure, they were worse. Second group, baseline tests, wrong thing first, unmatched bias, they were worse. Matched bias, they were better. So a nice little 2x2 crossover study, which was able to show on the same people matching bias versus unmatching bias performance deficits on a validated tool. So if we were looking at left extension biased exercise, and these are exercises on the left purely in extension, which in our diagram would be the left lower quadrant, moving to the left, moving the left leg. 4-point kneel, very popular exercise, commonly used and wasted, unfortunately. We do it on one side. We do it just moving the problem leg, and this has become very reliable. You move the problem leg, we don't weight bear support on that problem leg. Same thing, this is given to people on both sides with no consideration of their directionality. And often flexion biased people who don't tolerate and given this exercise, compliance is poor, outcome is pretty poor as well. On the machines, hands off to the left in extension. This exercise, hands off the left in extension. So these are left extension biased exercises. On the other side, these are right flexion biased exercises. Moving the right leg in flexion. In flexion, standing on the machine, hands to the right, you're in flexion. Sitting on the machine to the right, you're in flexion. So we've applied this across various levels of sport and general public. Is it reliable? We also did an integrated reliability study, also through Otago University, and found that yes, we're able to achieve a 0.87 kappa, near perfect, with 21 people, which was better than other movement-based classification systems. With only 4 or even 13, we're now up to 21. So we know it's an extremely robust tool for classification of treatment. How does this work in the clinic? And this is the simple thing. Everybody's got a phone these days. Everybody's got a camera on their phone. Video things. Everybody's video everything these days. So we've been doing the same, looking at these within subject, within session changes. So simple tests. Our patient here, simple tests that can be done, a range of tests, easy to do, such as lower limb function in this case, single leg squat on the left versus single leg squat on the right. And we can see there's a problem now. This is a chronic condition. It's been treated as a weak glute tendinopathy, call it what you may, but it hasn't responded some 2 years down the track. Potential here was for surgery on the hip. They don't know why, neither do I. But could we avoid that surgery? Could we change this person's function without focusing on the muscle or the structure that was lined up to be operated on? So we're seeing poor function on that right compared to the left, so we've got a within subject control, and that is the opposite limb. And it won't surprise you to see that this is pretty poor function. Now, we found from the patient history, the process we'll be looking at in a moment, that she preferred extension, and of course the problem is on the right. So applying this right extension model, first of all, let's have a look at our measures. Scoring out of 5, on the left she gave herself a function of 4, 4 and a 3 on the squat, the rise, the hop, and on the right, 1.5, 2.5 and 1 on the right side, so there's a 40% asymmetry. The intervention treatment was just exercises on the right, just exercises into extension, and then retest. Current post-intervention, We're looking here, as we can see, it's the same patient on the same day in the same situation doing the same tests, one variable, and that had been the intervention. We have a very different function. We haven't strengthened a muscle within a matter of minutes. We haven't repaired a structure within a matter of minutes. We have been able to change neural drive, neural function. And the first thing from this saying, well, is structure at fault? Is surgery going to provide a resolution? Can we get numbers? So we've got a significant change in function. And when we put measures against this, she scores herself a 4.4, 3.5. So a 3% difference is not clinically relevant. However, scores herself 3.5, 3.5, 3.5. And we've found here we have a 37% change in function within session. We can say quite categorically surgery is not required. We have a conservative program. We can manage this patient. We've just saved $25,000, $30,000. This is where the value of physiotherapy needs to be driven. So looking at this process, looking at other exercises, single leg balance training, elastic band, halter stability, looking at proprioception, time frames, how much change can they get, 13%, 20, some get better, some actually get worse, things that are commonly done, strength and elastic band balance training, people get worse when you actually measure it. Wobble board, that can be better. But these are all happening over 2 to 4 to 6 week time frames. We found through the Otago study, a post hoc analysis that was done, a 26.9% improvement within session in 16 minutes. We haven't published this yet, but we did present this as a keynote discussion lecture at the last World Rugby Cup conference in 2015 in Wales, and we were relating it there to ACLs, the most expensive injury in sport. Again, you improve proprioception in ACL deficient knee, they'll function much better as opposed to strength. And strength focus is now starting to move to proprioception for reduction of these. A lot of players are now going and opting for non-reconstruction and back performing. We've got Olympic skiers, footballers, AFL, we've got them also in the Premier League, are all over the place, general punters, doing very well with ACL deficient knees, managing to work on proprioception. So, what are we looking at? Clinical Pilates treatment. You've got two main groups. You've got your acute patient, and these are the ones where, yes, they've had a tear, they've gone over, they've ruptured a ligament, it's blue, it's swollen, it's sore. We micromanage, of course. We're going to look at this and apply local tissue-based processes, and we know the time frame, 4 to 6 to 12 weeks, it should be doing well. An ankle sprain by 4 weeks should be doing quite well. Certainly by 6 weeks. If it extends beyond 12, 15, 20, a year, 2 years, we can no longer blame tissue. Yet we're still seeing this where people are looking at tissue, looking at structure for something that's had a lot of tissue management, a lot of structure management, and still not functioning properly. So once we get beyond that acute, get into the chronic, we start standing back and looking at function. Are we just treating the symptoms, or are we actually looking at the system and how it functions? So this is the macro management model. Look at the big picture, look at the system. This regional interdependence, that's the model of looking at, is there more than one thing going on? Yes, it's their whole right side. So the knee in isolation may not be the problem. The knee pain doesn't mean it's a knee problem. So we're looking at the cause, not just the structure. So what is this directional model? Well, we're going to keep it very simple, moving beyond the structure, and then we can look at 4 key factors. As I said, most injuries are asymmetric. You'll hear this in patients if you haven't heard it already. They will tell you within a very short period of time, this side's stuffed. This side has all my problems. So the body chart tells you one side. I've had a hamstring, but I've also had a glute problem, and I've also had a calf and a tendonitis, tendinopathy, tendinalgia problem. I've also had a bit of low back pain, and that's their problem. We find the easing factors are their preference. These are the things you include in their treatment. The aggravating factors, we always ask easing and ag factors. Aggravating factors, in this case, it could be flexion. They prefer extension as an easing factor, that's an inclusion. If flexion was an aggravating factor, that's an exclusion, and trauma we're finding is a big one. History of trauma, how did they do it? We heard about the bending, lifting, twisting injury. That should be a big giveaway. There's been a flexion problem with it. Yet so many programs involve putting the patient in flexion, wondering why then they have a poor outcome. So to categorise the patient in a right extension bias here, we've got a body chart that shows right, easing factors that show extension. I love walking, I love swimming, I love standing, wearing high heels. All of those are extension preference. Aggravating factor is flexion, so we eliminate flexion from the intervention. And of course, trauma. So it's a process of elimination that leaves you with one option. That's a hypothesis which you then have to test. This is called heuristics. And heuristics is used in military, it's used in air crashes, it's not used in medicine. How do you make quick decisions with high accuracy? We think it's paradoxical. We need to have all the information. The more you know, the better it is. This is not the way it works. There's a point at which too much information hurts, and of course we need this accuracy for effort. 4 things. If we look at Goldman's decision tree for heart attacks and predicting cardiac failure, 4 pieces of information is all that's needed. Goldman's decision tree. Ottawa ankle rule, same thing, 4 bits of information. Cerebellar stroke, hints, head impulse and nystagmus test of skew, 4 bits of information, which is better than an MRI for predicting cerebellar strokes. So the more we look at it, 4 bits of information is better than 40. So these complex problems aren't really that complex. We don't require complex solutions for complex problems. There is also a model for this, bias variance dilemma. We won't go into this, it'll take all day. But you want to eliminate variance, you want to eliminate noise from the system. The more noise, the more variance you have, the harder it is. The basics of research. So, short story is, we've got to work hard, we've got to think clean, make it simple. Steve Jobs, the most successful corporation on earth. Apple made it simple by giving less choices. And they're still, I think, the leading corporation on the planet. You don't have time to dick around. You only got 15, 20 minutes, half an hour with a patient to decide what to do. You won't get patient buy-in if you start throwing a lot of things at them without any idea of where you're going. So, what's in a name? Where does Pilates fit? We know the Department of Health has had some questions about Pilates. That's being reviewed at the moment under the health reform model, saying there was no evidence, but there is evidence for clinical Pilates. The MBCT model too, physio-based, that does have evidence. There's more being published at the moment, there's more being tested at the moment. So Pilates is not the same as clinical Pilates. They are very different models. And as the APA has said, physio is physio. This is treatment, not separate from, but it's completely wrapped up in. So the clinical Pilates movement-based classification and treatment tool is physio, because we are treating patients, assess, intervene, then reassess. So there will still be the case for the pathoanatomical model, the reductionist exclusive. Yes, we can see something that looks like a disc, tastes like a disc, smells like a disc. Everything points at it being a disc. There will be then you treat it like a disc, it gets better. There are certainly those pathoanatomical structures that play up. We can also be playing the socio-psycho-biomedical model is now being called, and that's at the other extreme. But you'll very quickly get the psycho side of it sorted out, because the patient will see the change quickly and you have patient buy-in. The bio, we can exclude a lot of structures from it, saying, well, that doesn't behave like a disc, so we can exclude that. Certainly a good thing you didn't go off with surgery on the discectomy. And of course, how long will this take? We've seen the time frames are short. The time frames are very good, and they can get back to their sport, get back to their life as they wish, not going into hospital. So we're looking at something that's simple and adaptive. It fits between the two. We can certainly include and exclude pathoanatomical. We can certainly fit off the biopsychosocial and the more recently discussed socio-psycho-biomedical model as physios and get some effect from it. Okay, you've learnt the rules. You know what they are. Now I'm going to teach you how to break them. Yes, everything you've learned doesn't go away. That is your reference point. You've got that there to go back to, but there's a point at which you say, what else can I do? I'm under pressure. This patient's not getting better. Everybody else has treated them. What can you do different? So thank you again, and look forward to seeing you in the profession and solving problems.